I will start with asking who is sick and healthy, and then I will present a new dynamic model of organism-environment relations. Then I will ask again who is the biological patient in COVID-19 regarding this model. And I'll talk a little bit about epistemic justice in healthcare and in medical research. And in the end, I will suggest some future research. So in the biomedical context, patients are typically viewed as individual organisms, and their health maintenance is perceived as one of the medicine's main goals. And everything which is not the part of the individual organism unit is usually understood as simply as environment. In the context of public health and epidemiology, ecology medicine approach, such as One Health medicine, the focus is shifted from the health of individuals' organisms to the health of populations, ecosystems, and even the biosphere, as we heard before today about the Gaia theory. I argue that health state is attributed to an agent, and therefore medicine should establish wider categories of patients than the individual organisms, which are currently not clearly defined. And one of the reasons that I think it's not defined in medicine is that the medical field is still holding the dichotomic understanding of organism-environment model. In this research, I was inspired by discussions in philosophy of biology about holobiont research and the possible split between organism and biological individuality. And I created a model which presented a more dynamic understanding about organism and environment relations. The new understanding of biological individual as a dynamic collective blurs the distinction between the living being and the environment more than we saw ever before. The microbes previously considered as part of the environment are now, for some perspectives, understood as part of the patient, of the individual. So that's the ill body that we carry to the doctor invites by itself different scopes of biological patients. And in addition, there are other scopes of patients that are not present in the doctor office. This is the model I suggest. I'm not going to talk a lot about it, but if there'll be some questions after, I'll be happy to answer. I suggest that this new dynamic and gradual model accounts for organism-environment relations, and it allows to define more precisely the patient in different medical contexts. Instead of organism-environment, I introduced the living being in its exterior. Living being may refer to what we often understood as organisms, but it's also can refer to extensive collectives such as holobionts, ecosystems, or the biosphere. And these living beings may also function as part of a gradual environment, which I call exteriors. So there is 4 domains to the model. Every domain includes a living being and an exterior. In the first domain, we can see the organism as a living being and the organism as environment, for example, for cells. And the second domain, we can see the individual in what I call dynamic environment, which is external to the organism, but part of the individual itself. Domain 3 include the ecosystem and what I call interactive environment, which is external to the individual, and the individual interact with this environment, which is part of the ecosystem. And in domain 4, there is the biosphere and the inter-ecosystem as the exterior. With this in mind, I would like to present how I see the patients in COVID-19 regarding to this model. So according to the World Health Organization, we see that COVID-19 symptoms commonly include fever, dry cough, fatigue, and in severe cases, diseases might include symptoms like shortness of breath, resistance of pain, or pressure in the chest. And all these symptoms appears in and experienced by the human organism, and therefore attributed symptoms to a patient refer to common understanding of the patient as an organism, which is the first domain. There's a possible link between the development of the disease and the gut microbiota. This possibility might contribute to the explanation of why patients with a condition associated with dysbiosis like type 2 diabetes, cardiovascular disorders, and the elderly are more vulnerable to develop more severe cases of COVID-19 and can potentially explain some of the clinical manifestations. If this is the case, the treatment is not only directed to the host organism, but should also take into account the symbionts community. And possible treatment might aim to cure the symbionts community that changes the holobiont composition. So according to the model, the holobiont could be also a patient in the case of COVID-19. Another related phenomenon that affects what I call the dynamic environment is the low diversity of microbes in the individual as a result of high hygiene and social distancing. During the pandemic, people are staying mostly at home, avoiding meeting others for a long time period, and using face masks and antibacterial sanitizers with any encounter with their interactive environment, which is not their home. And these measures leads to less exposure to a range of microbes. Some of them, as discussed before, are beneficial and even essential to maintain our health. Some microbes are important for normal function and development of our immune system, and lacking them could potentially be harmful. This potentially can be harm especially for newborns who are not exposed to diversity of microbes during the pandemic as they would otherwise were. The next patient is the ecosystem patient, which is domain 3, that can be defined in different ways. It can be defined by populations in different geographical locations as states, cities, neighborhoods. We all know that they are colored by the rate of infection in their area. It could be on the basis of age, and the clinical characteristic and manifestation of COVID-19 are different in young, middle age, and the elderly patients. And it could be also differentiated by association or disassociation to risk groups. And lastly, there is the biosphere, which is in domain 4. Although we don't know yet the virus origin, there are strong reasons to believe it's emerged from zoonotic sources, as we discussed earlier, also in regard to other SARS viruses. Some close viral relatives of the virus found in bats and in pangolins, but we still don't have enough evidence to know how it jumps into humans. But irrespectively for its origin, we know that animals can serve as reservoirs of the virus and spread it. We all heard about the outbreaks that happened in mink farms in Denmark, Netherlands, and Spain. So those studies of other species and not only individuals, humans, is crucial for understanding the viral function and efficient control for further outbreaks. So seeing the ecosystems and the biosphere as patients and not only as external parts that affects human health can change how they are perceived. The models give some room to discuss the variety of patients in the same manner and not only as a metaphor. The ecosystem, accordingly, is not only a social construct, but a patient. And public health decisions in regard to COVID-19 putting many times the individual patient and the ecosystem patient in tension due to its high contagious and rapid spread. And we heard about it more today. Social discussions that we have. In addition, the model has to pay more attention to who is included under the title of ecosystem patient and who is left out. And the prices that paid by individual patients were excluded from being part of these ecosystems. The model also visualizes and can help us to highlight how inequalities affect the spread of and manifestation of the disease. One can also ask how much research and resources are invested in the different scopes of patients. From a medical perspective, it invites us to examine whether the medical attention goes to the right biological patient in specific context and highlight inequalities between different understanding of the patient. So one can ask how much do we tend to go beyond our anthropocentric view and put other species in the center of the model, seeing other scopes of living beings as patients allows epistemic justice. It allows us to consider the voice of the silent and excluded patients. Putting the organism, the individual, and the ecosystem and the biosphere on the same scales open a new range of discussions regarding the different interactions with the social and phenomenological perspective. One can ask, can an ecosystem or a biosphere be ill? How does equality of care look like when there are 4 potential biological patients categories? And what is the role of empathy in the recovery processes? These are just few examples for further research. That's it. Thank you.